Dive a lot deeper into the physiology and the energetics of the menstrual cycle. So in the early follicular phase or the menstrual phase, what's happening on a physiological level is that progesterone and estrogen are withdrawing as a result of failure of embryo implantation. And that's the case whether you tried to conceive or you didn't try to conceive. If there's no embryo, then the body will begin to shift towards starting itself over again, a menstrual reset. So what we mean by the withdrawal is that the body stops producing it. The corpus luteum doesn't get the signal of pregnancy, which comes from the pregnancy hormone HCG. So it doesn't get the memo that there's a pregnancy going on. So it's going to begin to shrivel up. It's going to stop producing progesterone, and estrogen levels will begin to fall as well. And then from there, the spiral vessels, which are the vessels in the endometrium itself, making the lining, providing blood supply to the lining, they become ischemic. So the body stops sending blood to those spiral vessels that comprise the lining. And that's because they are sensitive to the steroid hormones, right? So if they're getting the message from estrogen and progesterone to keep staying thick and fluffy, they're going to do that. But when you start withdrawing those hormones, then they stop having blood supply, or their blood supply begins to dry up, essentially through like a necrotic process. And that comes again from degradation of the corpus luteum. And then we have those spiral arteries become necrotic, and then they get expelled. And that is essentially what your period is. So the most superficial layer of the endometrium is what's being sloughed off through this process of necrosis and expulsion. So in those first days, when we've had this major withdrawal of hormones, and then the process of sloughing going on, these hormones, estrogen and progesterone, are very low. They're at their lowest state. And slowly, LH and FSH begin to rise. And already by the third day of the cycle, even though you may still have menstrual bleeding going on, estrogen and progesterone are back in the game, and they're beginning to control that glandular epithelium, that lining, the glandular aspect of the lining, and then proliferation begins again. So then we have new spiral arteries coming in that are full of blood and that are bringing all of this nourishment into the uterus once again. And then it's already ready to go by day 5 or 6. It's remodeled. We've got a whole new lining, and the thickness slowly starts to increase. So this is the first 5 or 6 days. You got bleeding happening on, from the old lining, the old stuff, and then you got a new lining coming in right behind it, ready to go. In an energetic sense, what we're looking at, the lens through which we want to look at this, is that on day 1 of the cycle, the Chongmai begins to empty itself out. So the Chongmai is the sea of blood, and we're going to talk about this later, but the Chongmai is going to begin to empty, and the Renmai is going to help to drive blood flow downward and for a healthy expulsion of the lining. The Yang will reach its zenith, and then it will begin to decline, and that's the beginning of that withdrawal. Yin also reaches its lowest point around that same time, and then immediately begins to proliferate again. So in the early phase of the menstrual cycle, days 2 to 4, the Chong vessel completely empties itself out and then refills as yin and blood build behind that shedding endometrial lining. And then by day 5 or so, we have a dominance of yin energy. And that's when the proliferation really ramps up. Between day 5 and day 12 or so, that's when we're going to see that lining thicken from 1 to 2 millimeters all the way to, 8, 9, 10 millimeters in most cases. So we want to support really good menstrual flow. We want to help patients have complete periods. And that will help to clear heat and prevent future blood stasis, help to prevent any kind of inflammation that can hang back and impact future potential implantation. So again, both of these things are happening concurrently. Both of these things are the same thing happening. It's just two different ways of looking at it and seeing that through our medicine and our approach, we can have an influence over how this goes. So once we get to about day 5, we're in what we would call the mid-follicular phase or the proliferative phase. And what's happening in a physiological sense here is that follicular recruitment is happening because of rising FSH and LH levels. So follicle stimulating hormone is being released from the pituitary and telling the follicles to grow. It's stimulating them to grow. Luteinizing hormone as well is slowly rising, and we'll talk about the role that it plays in this follicular development in a few slides. AMH, which is produced by the granulosa cells of the ovaries, inhibits excessive follicle recruitment. And this is really important. This, I think, has influenced me a lot in my understanding of AMH and why I don't get too worked up when there are low AMH levels among my patients. It was actually Randy Lewis who I learned this from many years ago, and it just stuck with me in a way that I think is so useful in thinking about AMH, because again, it's such a something that stresses patients out so much when they find out that they have a low AMH level. So the role of AMH really is to inhibit excessive follicle recruitment. So what that means is that the more AMH you have, the more follicles you have, the more AMH you need, right? And the way that Randy described it, and I'm going to describe it to you, is that AMH is like a dam. Its job is to hold back a huge flood of primordial follicles coming into the developmental stage. And that is in large part because as humans, we are not designed to carry litters. We're not meant to have high order multiples. Our pelvises are not equipped for that. We see in our regular practices that patients, often struggle in a much higher risk pregnancies, even with twins. But when you get into triplets or quadruplets, you're looking at extraordinarily high risk pregnancies with, pretty risky outcomes. So AMH is a way to inhibit too much follicular development in one given cycle. And so if you have a lot of AMH, that means you have a lot of eggs. If you have less AMH, you have less eggs, but it doesn't mean you have none. And it doesn't have anything to do with quality, because you can have low AMH when you're 29 years old because you have, diminished ovarian reserve. But that doesn't mean that the eggs that you do have aren't going to be healthy. Our biggest obstacle is always going to be age. So we'll talk a lot more about this as we go on and we get into things like advanced maternal age and premature ovarian failure. But it's important to understand the role of AMH. It doesn't mean a patient is infertile if they have low AMH. It doesn't mean they have poor egg quality. It just means that the amount of AMH they have is in relationship to the primordial follicle pool that they have left. And that doesn't really have so much of an impact on whether or not those remaining follicles are going to turn into a healthy pregnancy and birth. It just means there's going to be maybe less of them that are visible to us on ultrasound, for example, on like day 2. So what we have happening in days 5 through 7 is that follicular recruitment is taking place. Typically, the body is going to recruit 1 lead follicle if left to its own devices, sometimes 2. AMH is present to make sure that there's not an excessive amount of follicular development taking place. And then once the lead follicle is recruited, it will begin producing higher levels of estrogen. And that is because that lead follicle is going to have increased receptors and increased blood supply. And so those levels of estrogen are then going to send a signal to the hypothalamus, and the hypothalamus is going to become aware that, okay, we have a follicle that is starting to grow to a lead status, if you will. Estrogen then also supports the thickening of the lining itself. So the higher those estrogen levels are going, we're going to see correspondence there in the thickening of the endometrial lining, obviously with our X-ray vision or with our patients who are getting regular ultrasounds. And then there will be this increasing thickness, density, and spiralization of the blood vessels and the glandular cells. So the body is starting to prepare for ovulation and implantation. From an energetic sense in the proliferative phase, we're looking at, it is yin, it is the yin dominant phase, but of course there's jing, right? That follicular activity is really prenatal jing that we're influencing with the postnatal jing support and yin support at this point. Yin and blood are what are creating this thickening endometrial activity, or what we would refer to as the filling of the Chong vessel that's taking place during this proliferative phase. And then the successful progression and transformation through this phase is dependent on enough yin, enough blood, and enough jing. So we want to make sure that we're really shoring up our patients' resources. And that doesn't just come from acupuncture or herbs, that also comes from lifestyle and nutrition and mindset and all kinds of different variables. And so as we're doing that, then we're sort of setting the stage for a healthy ovulation and a healthy then luteal phase, where there's a warm enough state within the body, there's enough yang, and the stage is sort of set for receptivity for implantation.